Hello everyone, this is one more edition of our POCUS Monday, talking about point-of-care ultrasound, and not only point-of-care ultrasound, because POCUS is clinical, is medicine, okay? And I'm with Dr. Kate Dindi from Kenya, and Dr. Kindi, you are so Dindi, it's right?
Yeah.
Dindi.
Yeah.
Your work is so insightful. He leads a program on cardiac surgery and general surgery in rural areas in Kenya, and is also a father, a family guy, 3 children, and working in rural areas and so on. And Dr. Dindi, please talk a bit about yourself and what is your journey in medicine, and particularly with point-of-care ultrasound.
Thank you. Thank you for having me. Very kind of you. Very kind introduction. Yeah, I'm Kate Dindi, a doctor here in Kenya. I'm a cardiac surgeon, but really passionate about getting access to the underprivileged in our society. And so working in Africa is very fulfilling for me. I got into medicine because of my own experience. I was sick as a kid. So when I was 9 years old, I had a huge tumor on my neck. And I was taken to our local district hospital. And we only had one surgeon covering hundreds of thousands of people. And so it took a very long time for me to finally get the care that I needed. And when I finally got the operation done, I remember just having conversation with the surgeon. He was so sorry that he had kept me waiting for so long, but he explained to me that it's because he's alone. And that's when I made the decision, this is what I want to do. I wanted to one day go back and help this gentleman. And so that's how I got into medicine. To cut the long story short, that's how I got into surgery specifically. And it's been a fulfilling journey. I've worked here in Kenya. I've worked outside Kenya in the developed world for some time, but I made the decision to come back because I felt I was needed here more than I was needed in the Western countries. So I've been very excited to be able to be of service to our people.
No, Dr. Keith, and because then you had your studies in Nairobi, yeah? You studied medicine in Nairobi.
Yes, so I studied the model here in Kenya, you have to do 6 years of undergraduate training.
Okay.
Then you do 1 year of internship. Then after that, you had to work for at least 4 years before you would be accepted to do postgraduate in surgery. And so I did general surgery first for 5 years, but I was interested in cardiac surgery. So after that, I went and did a fellowship in cardiac surgery that included training in Australia as well. And so that gave me quite a bit of exposure before coming back to work in Africa.
Okay, and then you came back to your old town, yeah?
Yes. So immediately after finishing training, I had the opportunity to go back and work in my old town. And that was very, very fulfilling. I actually met the old surgeon. He was now much older, of course. Yeah, but I told him, hey, you're the one who inspired me to do this. And that really made his day. I remember him misting in the eyes when I told him he's the one who inspired me. It was a very powerful moment indeed.
And now, what are the unique challenges that physicians and surgeons face in Nairobi compared to other regions in Kenya? Because you have a lot of disparities, yeah.
Yes. So and I have worked and work is still in the rural areas and again in Nairobi. So Nairobi is our capital city, and so the experience in the city and this experience in the countryside is completely different. So you have very many good facilities here in the city, But back in the countryside, there are places where you'd probably need to travel for hundreds of kilometers before you get what you'd call at least a level 4, level 5 kind of facility. And we still have some areas where access to basic healthcare can be a great challenge. So access is one thing, but the other thing is affordability. So many people in the city, they're covered by private insurance and things like that. So they're able to afford care at a certain level. But one of the challenges of medicine now in the rural areas, even where you have some facilities, patients are not able to pay. And so that makes it very challenging when you want to offer them world-class care, but then the affordability becomes a problem. So that presents a very unique challenge.
So point-of-care ultrasound could be like a help in those rural areas because it can democratize the access to exams that otherwise, like only with the physical exam, will be very difficult to tell, no, this is an emergency or this is a thing that we need to transfer. What are your experience and what is the role of point-of-care ultrasound actually in Kenya? If there is at all anything organized or...
No, absolutely. I think it's very interesting because just last week I faced this as a personal experience. I was called very early in the morning by some people, and they told me, "Hey, your sister and her family have been involved in a road traffic accident very early in the morning, and it was away long distance from the city." And so when I was called and I asked, "What is their state?" and I'm told they're strewn all over the road. There was a huge truck that crashed into their car. And so the police rushed them to the nearest facility, and it's not exactly top state-of-the-art facility. And so they were rushed there. And when I was told, I immediately got into my car and dashed to see how we could help. And I got to that facility, and there was no capacity to do the investigations ideally you should do when an accident has happened. And so we were wondering, some of her children were wondering, do they have internal bleeding? Do they have injury that would be concerning? There were obvious limb fractures, but we were more concerned about some of the other injuries that can be truly life-threatening. And that is where I used my point-of-care ultrasound. I'm not a radiologist, but as a trained physician, I've been using this for a long time, and we were able to quickly determine who needed to get quick surgery and who needed just to be sorted out with the limb injuries. And this was my own sister. It was my own sister with
your own sister, and with your own you have an ultrasound machine, your own ultrasound.
Yes, I have my own. And I used that to be able to check out, and it was really helpful to the team on the ground. So when we talk about point-of-care ultrasound in settings like ours, where you might not have radiologists on quick call, I compare, for example, my experience in Melbourne, Australia, where we had I could just call, and the radiologist was always at the hospital. There were quite a number of ultrasounds that could be moved around the facility. These facilities we do not have, or you have one proper ultrasound machine with one radiologist. They just cannot be able to move everywhere. And especially when you have scenarios like this, when you have an accident, there are many victims. These are the places I actually feel point-of-care ultrasound, it's like it was meant or made for resource-limited setups.
Okay, man. This is a great message. And you answered, I had another question, but you already answered, because the diagnostic tools and treatments in these regions are very, very difficult. And do you use like telemedicine or like bridging the gap for remote patients? Or
yes, so let me just mention one thing about point of care just before I moved to the telemedicine. I think the fact that having the point of care ultrasound POCUS, as we like to call it, can actually make a difference between life and death, to me is a very powerful perspective to have, because there are patients, especially in terms of referral systems in our countries, knowing the clinicians getting to know whom to refer and whom to refer quickly. Those decisions are really helped by having a point of care ultrasound. And so physicians having that extra tool in their hands helps them to refer patients to us. Like, I'm a cardiac surgeon. There are patients, we in our continent, we study cardiothoracic medicine. We don't have thoracic surgeons separate from cardiac surgeons. So I have handled a lot of patients with thoracic trauma that would otherwise have died if somebody had not made the correct decision in time. And so I can't overemphasize the role of point-of-care ultrasound in making life-changing decisions, in just being an extra tool, armor in the hands of clinicians, especially in the remote areas. I really wanted to emphasize that.
Yeah, and we are jumping to telemedicine. I want to highlight, because it's not a solution, okay? Because remote areas have also bad communication system, yeah, and you need to have a strong, like, and if you have a strong communication system, probably you may have also machines in the place. So I think it's more reasonable to train and to train physicians in remote areas doing ultrasound. Do you agree? Yeah.
Absolutely. I think there is need to train not just doctors, but various cadre of staff.
Yeah.
Because some of the smaller facilities are run by people who are not doctors. You have clinicians of different cadres in our setup. So there are even some smaller units, dispensaries, where you probably just get nurses who are manning those units. So I feel it's so important for these skills to be in the hands of the whole spectrum of people that encounter patients, from the nurses, the clinical officers, doctors at various levels, consultants. I think it's just one of those things that the way we like to hang stethoscopes on our shoulders, I feel we should, in this day and age, be having a little ultrasound probe in our pockets.
Yeah, Dr. Dindi, just after, before we start our conversation, you had to stop like 10 minutes because you had a case which you used ultrasound. Tell us a bit more about what happened. You are in the hospital now.
Yeah, this was just last night. So last night I was called in because there was another gentleman that had been involved in a road traffic accident. And when he came in, the referral team, when I was called, they said they were concerned that this patient has some blunt chest trauma. So they were concerned about some lung contusions. But specifically why they called me as a heart doctor, they were concerned about a perforation on one of the chambers of the heart from what they had seen. So they sent the patient over, and I rushed to go see the patient. And once again, with just a quick look with the probe, I had a look and I noticed that there wasn't any effusion around the heart.
Okay.
And I felt it's very unlikely that there could be maybe a chamber injury. And later on, when now the cardiologist came and did a proper echo, they agreed that really there wasn't that need for concern along those lines. And I was able to look at the lungs and notice, yes, there's indeed some pulmonary contusion, and we were able to handle the patient that way. So just having that probe and those skills were able to help me from the very word go, give reassurance to the family, manage the patient without really escalating care or even getting maybe more investigation. So that was very helpful.
Dr. Kidd, you are working since yesterday, yeah?
Yeah, this is
called in the night. Now you are night in conversation. Thank you. Now it's like the final message you like to share with this global world and communities. And please tell us what you feel, and with your hard work and inspiration, it's so insightful. And I would please to hear from you a final message. Okay.
Yes. I think working together as a global community, because we are all human, and when humanity suffers anywhere, humanity suffers everywhere. And so I feel it's our role as people of goodwill, clinicians of good conscience. Can we put our hands together to make a difference, even in places where people might not be able to afford healthcare at its very best? So I think we can work together as a global community to, as I love the word you use, to democratize access to proper healthcare. And I think POCUS helps us. It's one of the tools that helps us to get there. So if we can work together, ask ourselves, what is it that we can do? When I was leaving Australia to come back to Kenya, that was the question in my mind. I said, what can I do as an individual to make a difference? And so there's always something we can do as individuals, but it's more powerful when we come together as communities to work and make a difference. One of the things that I think is an easy win in terms of just working together to provide training for clinicians across different countries in Africa. I have such a passion for this continent. And so I think if we can put our hands together to provide training, we can then lobby governments to provide access probably to the ultrasounds themselves. But as a low-hanging fruit, I think this aspect of training is something that we can work together as a community to make happen. At the end of the day, we are here for a short period of history. Each of us will not be here in the next 90, 80 years. So if we can leave a mark, and I think POCUS gives us an opportunity for all of us to leave a mark, especially in terms of training. Let us put our hands on the plow to make a difference, specifically, I would say, for the continent of Africa.
Dr. Keith, it was the most beautiful words I've heard in the last month, okay, man, because the world is so full of hatred and wars and so on, and conflicts, that they are not like the solution. We are in conflicts before trying to talk and to share the knowledge and to see like this. We are finite, very finite in our lives in the earth, and to leave this earth without leaving a difference or a small difference is so sad.
Absolutely.
Thank you, Dr. Keith.
Thank you.
And you are an inspiration, even as me, that I'm working in a rich country. Portugal, we are always saying that we are a poor country. No, we are very, very rich. We are in Europe, you know, and so many resources that we don't have like a proper contextualization that we have, and always complaining. And thank you for having this conversation with you. Okay.
No, thank you so much. I really appreciate and thank you for the good work that you're doing. And I would really love to host you in Kenya. Think about it. You guys should come.
We have to work together, and this is the first touch, okay?
Sure.
Let's put it on, okay, man?
Absolutely.
Thank you.
Thank you so much. God bless.